Important in the coming days is the simulations in anesthesia. Dr. Dheerja Sharma, who is a vice president at Max Healthcare Institute Limited, Max Super Specialty Hospital, Shalimar Bagh, and she has interest in medical education, palliative care, difficult airway, and quality in anesthesia. She'll be comprehensively discussing simulation and anesthesia and its role in the upcoming time. Over to Dr. Dheerja Sharma.
Today, I will be talking about simulation in anesthesia, a very interesting and hot topic indeed. At the end of today's lecture, you should be able to talk about and understand the concept of simulation, know about brief history of simulation, what are the uses of simulation in anesthesia, classify different types of simulator, know the advantage and disadvantages of different simulation-based trainings, and of course know what is the future of simulation in anesthesia. The simulation refers to the artificial replications of sufficient elements of a real-world domain to achieve a stated goal. In this picture, you can see a man learning how to drive on a simulator. 40 years back, I remember when I had also started learning how to drive a car, I actually learned it on a simulator, an auto simulator. Not only did I perfect all my physical maneuvers on a simulator, I felt much more confident when I actually started driving the car on the road. So, second concept that all of us should understand clearly is fidelity. It refers to how closely it replicates the reality. Fidelity is determined by the number of elements that are replicated and the discrepancy between each element and the real world. So actually, fidelity is determined by the number of aspects that are replicated by the simulation or the stimulator, not only the physical ones. For example, in the previous picture, we saw that the man was sitting on a simulator which had obviously a clutch, an accelerator, a steering wheel, and a gearbox. But the applicable representation of each aspect relative to the end of real world determines the fidelity. So, not only learning how to maneuver these is important, but also in that simulator, we get situations like a dog suddenly crossing the road or another vehicle overtaking from the wrong side, or a baby suddenly appearing on the screen, requiring the learner to, to respond to the situation is a high fidelity simulator. So the fidelity required of a simulation depends on the stated goal and participant population. Simulation in fact is as old as the mankind. Rehearsal for hunting activities and warfare was most likely an occasion for stimulating and behavior of prey or enemy warriors. In medieval times, soldiers learned the art of swordmanship on dummy soldiers. Hundreds of years ago, models were used to help teach anatomy and physiology, and simulators were used to train surgical procedures. We know that, we've seen that. To help midwives and obstetricians handle complications of childbirth. In fact, all of us will remember how during a final prof before gynae exam, we will pick up the articulated pelvis and actually simulate the birth of a baby, because that is what we may be asked in the viva. Preparation for warfare had helped in development of simulation technology in last century, especially for aviation, shipping, and the operation of armored vehicles. In fact, in the 20th century, commercial aviation has contributed the maximum to simulation. What is the history of simulation in anesthesia? The first anesthesia simulation, SIM-1, was described in 1969 by Denson and Abrahams. It was developed as an aid in learning to intubate and to induce anesthesia. It consists of mannequin with intubable airway, upper torso and arms. So this is what we are all familiar with. We have seen this mannequin very often. We've used it to learn ACLS, BCLS. We know that this is what is being simulated, and we help learn intubation on this. So in mid 1980s, computer-based simulators were developed like Sleeper and Body. In 1986, Gaba and Deanda developed a full-scale simulator called the Comprehensive Anesthesia Simulation Environment case to study the decision-making process of anesthetists during critical events in Stanford. Gaba, Fish and Howard defined case to be used in development of Anesthesia Crisis Resource Management course. We'll be talking in greater detail later about this. Michael Good and J.S. Gravenstein developed the Gainesville Anesthesia Simulator, which later became the prototype of medical education technology METI simulator. Another simulator, TOMS, team-oriented medical simulators, were also developed at Basel. The uses of simulation in anesthesia are for education, for training and upgrading skills, to be used in research, risk management and public relations, performance assessment and recredentialing of clinicians who are in practice, and also used for design of OR and supply management. Before we go on further, let's look at the Miller's pyramid of clinical competence. Initially, when a student starts learning, they only go towards fact gathering. It's like learning the alphabets, and the student just knows the facts. In the second stage of learning, the student knows how to do. She understands, she is able to apply the knowledge. In such cases, this can be done with examples of case presentations, essays, and extending matching type of MCQs. Once the cognition of the situation is developed, when the knowledge is acquired, in the third stage, a student will learn to demonstrate the learning, and that is where the simulation and OSCE type of platforms come into effect. And once the learning is demonstrated, then the performance is integrated into practice, and this can be tested by direct observation or workplace-based assessment. And this is the pinnacle of Miller's pyramid of clinical competence. How are different types of patient simulators classified? A simulator can be based on the type of physical situation. So you have mannequin-based simulators, which can be full-scale, hands-on simulator, realistic simulators, or high-fidelity simulators. Second time are the screen-only or screen-based simulators, which are known as micro-simulators. And the commonest example many of us have used are the Gasman simulator. Part task trainers and virtual procedural simulators are also very popular. Part task trainers are the kind of simulators we use, say, for learning how to put in IV lines, the IV arms, or when we learn how to put the CVPs or the simulators, mannequins for doing cricothyroidotomy, for doing tracheostomy, and we may even use animal models for the same. Virtual procedure simulators are used quite often by the surgeons. The virtual reality simulators and augmented reality simulators are newer modalities, and we'll be talking about them. The newest development is having a complete virtual environment, which is totally computer-based. After that, the simulator used can be a standardized patient. So this is basically a human being who is acting out a patient's role. So this is a very common way, the common form that we use in workshops. For example, in the UGRA workshop, the ultrasound guided regional anesthesia workshop, you would have normal human beings acting out as patients, and we actually see the human anatomy and learn to simulate giving a block on those patients. And then it can be hybrid simulation, in which we are using both types, maybe different types of simulators sequentially. Simulation can also be divided on types of simulation. So we can have dedicated centers for simulation. These centers are not part of actual clinical facility. Therefore, we are just mimicking a clinical situation. However, the advantage is that these are dedicated and the trainers are undisturbed, the trainees are undisturbed, and they can devote the entire time to learning. But another disadvantage is that it is set away from clinical setting. A lot has to be imagined here. And secondly, it may be difficult to collate all the trainees together at one point. The second time are temporary institute simulation. In this, the simulation work takes place at actual clinical setting, so maybe inside the OR, but the simulation facility is temporary and it is taken down after the simulation session is over. So the distinct advantage here is that the trainee learns it in the environment where they will actually working. So the shift from knowledge acquiring to actual workplace is smoother, but obviously the disadvantage is that it disrupts the clinical settings, and we need to take some time out and space out for this to happen. Second is residential in-situ simulation. In this, the actual workplace is used and there's a permanent facility of simulation. The advantage here is same as in the previous case, but the disadvantage is that we need to mark out a specific place in the clinical setting which is set up for simulation. Therefore, it requires much more space and infrastructure. Fourth type is peri situ or off-site simulation. In this, the simulation is done, say, in a conference room. The advantage is that this is easily accessible facility in most places. It is cheaper. And the disadvantage, of course, is as in case of dedicated center, it is away from the clinical facility and a lot of the session needs to be imagined by the trainers and trainee. The fifth type is the sequential location, in which case we may move the simulation from, say, a dedicated center, and then part of the simulation may be done in a clinical setting or in a conference room. The last one is mobile simulation, in which the simulation facility move from one place to another. In our organization, for ACLS and BLS training, quite often the trainers and the mannequins move from one center to the other. So the advantage is that we need to have a smaller infrastructure and it can be used by many trainees. What are the components of a patient simulator? So you can typically see that a patient simulator here requires a core simulator component and then their simulator representation. Of course, there is a trainee who is the clinician, and the most important aspect of a simulator is the instructor. So the instructor chooses the patient and the type of events and scenario that they would be teaching, and that is fed into the core simulator components, which consist of model of the patient, and then there is an interface of the component with the simulated representation. That from the model there is output into the interface which goes into the simulated environment, and it is shown in as visual, auditory, and tactile actions. And this environment may contain the OR and ICU personnel, the patient who is the simulated patient, simulated clinical environment, and equipment. The learner, who is the clinician, then does some action in this environment. The action may be as in giving drugs or gases or maintaining the airway or doing some other action as in case of ACLS. These are all clinical actions which are again as input into the interface component, which go back to the model of the patient, and then again the model of patient as per the events and scenario puts the output which are seen as visual, auditory and tactile again by the simulated representation. Control logic for this can be the changes in simulated patient condition can be generated, controlled and sent to the appropriate output of the representation. And this can be done as a software as a fixed sequence of events, or there can be a manual control logic which allows scripting of combination of changes in control output. This is quite common in the lead rail simulator. We'll be talking about it, or it can just be a mathematical differential equation model, patient's physiology, depending on patient physiology and pharmacology. It can be a finite state model, instructed initiation of abnormal events, or it can be instructed operator station, which allows the instructor to create specific patients and select the abnormal events, faults, etc. This is the prototype example of a simulation center, and this is how the dedicated simulation centers are made. But when we need to mimic this also, when we are making on-site in situ simulation, so there should be a specific debriefing room, and where the participants and trainees are debriefed before the simulation session starts, and there is a control room where the instructors sit and control the input. Then there is the simulation environment. Here we can see that there is a patient, their trainee, and their other actors of simulation will be there. There is a video recording which is happening. There is an input which goes in from here to the interface, and then there is an output which comes from the interface into the towards the patient, and this is the complete interface environment. Mannequin based simulators are realistic, full scale, high fidelity and macro simulators. In 1986, Gaba and Deanda developed the case simulator, and the primary goal was of conducting research into decision making by anesthetists. So we realize, as we see the development of simulators, that initial simulators were basically simulators to teach this skill, where we learned how to intubate or things like that. As it developed, then the second stage, the simulators were teaching how to make decisions to the learner. And in the third stage, in the later development of simulators, we realize that we're actually learning the team learns how to react to the situation and how to perform better as a team. So the case uses commercially available mannequin, which is modified to enable occlusion of left mainstem bronchus. There is infusion of CO2, and insertion of intravenous lines can be also done. In this mannequin, we can do mask ventilation, intubation, auscultation of breath sound, but it did not have a palpable pulse and spontaneous ventilation. Case mannequins are extensively used in anesthesia crisis resource management training program, which is the third stage of simulation. Then this another type of high fidelity simulator system, medicine aid system. I'm just sharing it quickly with you. This is the mannequin in the middle, and there's an interface of training from left to the right, and the mannequin, we can do intubation. The mannequin has steering and also produce auditory reaction, and then we can see that there input and output cables which are coming out going to the interface card. There is a gas analyzer, and there is an NIBP simulator also available for the mannequin, and all these values come out as per the scenario which is decided, and also as per the result of the action which the trainee does. These high-fidelity patient simulator is completely operated by physiological, pharmacological, finite state models and detailed models of cardiovascular, pulmonary, fluid, acid-base, electrolyte, and thermal physiology. So, depending upon the action done by the trainee, the patient's physiology shows a differentiation and further action can be done. Then there are Gainesville Anesthesia Simulator and Meti-Human Patient Stimulator. In this concept of gas, this was an anesthesia machine modified to incorporate a variety of mechanical faults that could be triggered electronically. It featured a complex, quantitatively accurate physical simulation of multiple gas exchange. The lung concentration of oxygen, nitrous, and one volatile anesthetic could be physically made to match the alveolar gas predicted by a mathematical model. So here the trainee can actually change the gas flows and see the effect, change the dial settings and see the effect on patients' MAC values, alveolar concentration, and learn about how to give a more efficient and better word-line anesthetic to the patient. It was further developed by METI and is now called the Human Patient Simulator, which also uses full physiological and pharmacological mathematical models. The METI also offers a child-sized mannequin PediaSim. It can be controlled by the same base computer and the operator simulations. Recently, METI released a more mobile and much less expensive simulator called Emergency Care Simulator. This is the photograph of a METI human patient simulator. The mannequin rests on a standard ICU bed, and the linking hardware is contained in a separate card. And there's a loudspeaker in the headrest provided which gives patient's voice to allow mannequin to act as a standardized patient. So the mannequin will moan, will cry, or respond in different ways to the action of the trainer. The METI instructor and operator station can allow for multiple patients to be operated at the same time, and the patient values of physiology, ABG, etc., which come up as a result of the action done by the trainer are shown here on the screen on the patient. The blood gases, cardiocirculatory parameters, etc. The lateral SimMan is, they are manufacturers of basic life support and advanced cardiac life support training devices, and all of us are most familiar with these mannequins. They are used for code blue training. Then lateral SimMan was introduced in 2000. It's a virtual monitor rather than clinical monitoring system. So it is a cloud-based and much cheaper version, and easier to operate also, and its control logic is provided by direct instructor control of individual data values and setting. It can also be augmented by a script-based control logic. The SimMan mannequin during trauma resuscitation training, this is what we are using. The mobility and advanced airway features are there, and we can even put in chest tubes and manual blood pressure measurement in the patient to make this type of simulation well suited for training session outside the simulation centers. What are the desirable features of future mannequin base? So it should be advanced skin signs such as change in skin color, etc. should be seen. Diaphoresis, change in skin temperature. We should be able to mimic regurgitation, vomited, airway bleeding, physical coughing, convulsions. Purposeful movement of extremities should be there. There should be support of spinal, epidural, other regional anesthesia procedure. EG signals we should be able to see BIS, AEP, etc. Intracranial pressure monitoring, support for physical CVP cannulation, fetal maternal cardiotocograms, and a fully interactive simulator of a neonate and infant is the future. In screen-based simulators, Sleeper and Body are the examples. Sleeper use complex transport models to deal with gas exchange and drug distribution, and they predict concentration of drugs in specific anatomic region, say example in myocardium. In the ASC, provides graphic representation of mock monitoring displays and clinical equipment, and also photographs to display patient and action taken on it. They use pharmacokinetic and pharmacodynamic model. The Gasman anesthesia model is also a screen-based simulator. Then we quickly talk about virtual reality simulator. Virtual reality refers to a set of techniques in which one which interacts with a synthetic virtual environment that exists slowly in the computer. The action of the user and environment are translated directly from typical physical activity and not through manipulating a special pointing device. So the user is actually, when they move their hand or when they do a procedure, that is what is taken as the action, and not a specific thing done to the pointer device. Virtual reality is complete simulator is a complex entity as it requires a complete computer model of the patient, the environment, and the function of every object in the environment. There should be a means of tracking the visual, audio, and touch fields. Appropriate display hardware for every sensory modality needs to be given, and hardware to compute all models to conduct the tracking is done. So virtual reality is still under development. Quickly, I'll talk about the anesthesia crisis resource management. This was what was done by GABA and is used for using the case simulator. And in this ACRM, the trainee needs to know the environment, anticipate, and plan. So, this is a complete simulation of the entire teamwork and entire situation. The trainee is taught to call for help, exercise leadership and fellowship, distribute the workload, mobilize all available sources, communicate effectively, use all available information, prevent and manage fixation error, double check, use cognitive aids, re-evaluate repeatedly, use teamwork, allocate attention wisely. So you can quickly see that when an ACRM training is given, the trainee becomes a much more effective clinician with respect to actually responding to the real life situations. And in this curriculum, there is a comprehensive textbook on anesthesia crisis management, which is actually used, and small group exercising and analyzing videotape of actual anesthetic mishaps is part of this training. And several hours of complex, multifaceted, realistic simulation is done. We can use patient stimulation for training healthcare personnel outside anesthesia in the ICU, in the ER, the delivery room, as code blue team responders, in radiology, in field response by ambulance staff, and training of management of chemical, biological, nuclear threats from accidents, weapons of mass destruction, and terrorism. For this example, in this there is a realistic patient stimulation for medical rescue team and chemical protection wear. And in rescue situations with full protective gear, the communication within the team and patient is difficult and very important. And in fact, all of us will recall this very well when we walked fully into the pandemic 2 years back. This was the major hurdle that we had to come over, where the communication in the complete PPE was a major task. So imagine if we have had a simulator training on this, we would have avoided many mishaps due to the communication and learning as we go that we did in the pandemic. The use of patient simulator can be done in support of biomedical industry. Numerous centers offer training to executive and sales representatives to actually understand how their equipment are used by the clinician. They allow individuals to gain some understanding of clinician task demands during patient care. The simulator used to train manufacturers representative clinician in safe use of the drug, and it can also be used to conduct research on human factor issue in development of new monitoring therapeutic. In fact, it was possible to train anesthetists in application of remifentanil with simulator even before remifentanil was approved by FDA in the USA. Some centers use simulators for conducting outreach programs, say for high school and college students, for teaching them BLS, etc. Simulators used to produce educational videotapes can be used as adjunct in medico-legal proceedings, can be used to illustrate typical perioperative situations, the role of different monitors and therapeutic action, and can also be used in non-technical skills, soft skill assessments. The effectiveness of simulation training gives the advantage of it as a training tool. There is no risk to the patient. The exercise and routine procedure can be repeated again and again, and participants can learn to use actual complex decided with hands-on simulation. The same situation can be presented independent to multiple subjects. So we don't have to, the multiple subjects can learn the same thing again and again. Errors can be allowed to occur that in a clinical setting would require immediate intervention. The simulation can be frozen for discussion and complete analysis. Recording, replay, and critique of performance are facilitated. The research issues which can be addressed are for cognitive science and dynamic decision making in anesthesia, human machine interaction, teaching anesthesia in the OR. So, in the research, we can see how much teaching can be accomplished in the OR without sacrificing the team's vigilance. How well can faculty detect and categorize performance? What teaching styles are best? The teamwork we can research to see how does the anesthesia team interact with each other, how is workload distributed, how do team members communicate with each other and how do they communicate with other members of the OR team. It can be used for effects of performance shaping factors on anesthesia performance, for example, how sleep deprivation, fatigue, aging, etc. affect anesthesia performance. Can smart alarm systems or artificial intelligence provide correct and clinically meaningful decision support in operating rooms? For development of new devices and as a research regarding technique of simulation itself. What is the future? Patient simulators have emerged from their purely experimental phase to become an accepted and though still a new component of research and training in healthcare. It is highly likely that simulators will become a regular part of initial and recurrent training of most anesthetists. The anesthesia community can be proud of its pioneering role in developing patient simulation in technology and simulation-based training curricula. As this process continues, it is also likely that anesthetists will continue to lead the rest of healthcare in the evolution of this technology and its educational research and evaluation applications. In fact, the National Medical Council is now almost mandating that simulators be part of medical education everywhere. And the new medical colleges which are opening up are coming up with fantastic simulation labs and simulation facilities. The suggested reading for today's class, of course, is please go back and read your Miller's Anesthesia 9th edition, 7th chapter especially, and also do read the 6th chapter regarding the safety of patient to get a better picture on simulation. These are some of the articles you can refer to, and these are some of the online resources that you must go and visit. Society for Simulation in Healthcare and also Society in Europe for Simulation in Medicine to get a better understanding of simulation in anesthesia. And in fact, American Society of Anesthesiologists Simulation Education Networks provides very good simulation opportunities for you to actually practice and learn. To all of you, the future is here. It is now. Metaverse is the new reality. In fact, a few weeks back, last month or before that, it was reported that the first spinal surgery was done in a virtual augmented reality OR in the Johns Hopkins Institute by Dr. David, and he is a neuro surgeon and orthopedic surgeon, and he actually did the first surgery successfully on a patient where the CT scan and PET scan and all the reports were actually projected onto the surgical field. And he in one of the interviews shared that the entire experience was superb, and they could do very good surgery because of the augmented reality. And their team is routinely using AR and VR for simulation training of the trainees. Thank you.
Thank you, Dr. Dheerja, for covering up this not only upcoming, now getting established system of training and simulating many things in the present business. It is something like when we used to give anesthesia when we started our practice way back in late 70s. And now the people ask us, how did you see the pulse? How did you measure blood pressure and press the bag at the same time when you had none of these monitors there? So like same in the case of training, they would like to ask us, how did you learn intubating a patient when none of these was available? But I'm sure with this simulation, things are going to be very helpful because as you said, no harm to the patient. We can repeat it all the time. And whatever errors we have, we can see what errors have been made, how to improve them, and the teacher can tell you where you faltered. So that will make things much more comfortable for patients as well as for the doctors. So probably it is the need of the day. Dr. Lalit, can we have the next this thing, or we can have question answers? Okay. Okay, so next speaker is again in the one of the latest topics of discussion in anesthesia, which is enhanced recovery after anesthesia.